welcome, welcome, welcome. My name is Stacy Grondel. I'm the Director of Clinical Reimbursement for QRM. And today we're going to dive deep into that PDPM nursing component. Along with diving deep into that nursing component, we're going to talk about calculating the GG function score for nursing. We're going to look at the nursing components in their hierarchy, and we're going to learn about the end split. There are lots and lots of things to look at for PDPM nursing component. Many things impact it. It's not a simple yes or no. It's really diving deep into each of the different services that we're providing for the resident. So we're looking at those nursing services, the diagnosis, the conditions, the behaviors, cognition. We're looking at respiratory therapy, their functional score, which comes from section GG, their PHQ 2 to 9, as well as their restorative nursing. Fun fact, the PDPM nursing component actually is the RUGS 4 nursing component, just a little bit condensed, and a few things have changed, a few minor changes, but essentially it's the same thing. So if you understand how the RUGS 4 nursing component works, then this will be easy for you to learn. Plus, most of us have been using the nursing PDPM score for quite a few years now, as this is the same model that is used for Medicare A reimbursement. But I think it really warrants a revisit because it's now going to be impacting several states' case mix index one way or another. So I think it's really important that we understand how it works because it is impacting several things now. So the very first step when calculating your nursing component is to calculate that function score. So we know we've always used our late loss ADLs from section G. Well, now we're using these items from section GG. There are 7 different items that are used to calculate the function score from section GG. But I want to point out we're still using those 4 late loss ADLs, right? Eating, toileting, bed mobility, and transfers. Those are our 4 late loss ADLs that we're all so familiar with. Well, if you look closely at this slide that I have up here, eating is our first bullet. Toilet hygiene is our second bullet. So that's our eating and toileting. Then sit to lying and lying to sitting on the side of the bed. Those are bed mobility components. So there's our bed mobility. And then the last 3 are our transfer, sit to stand, chair to bed to chair transfer, and toilet transfer. Those are our 4 late loss ADLs. So even though they look a little bit different because they are broken up into separate pieces for the tasks, it's still the 4 late loss ADLs that we're looking at. So when we're trying to calculate that function score, you can get a total score of 0 to 16. And how you can do that is your bed mobility items, those 2 bed mobility items are averaged, and your transfer items are averaged. But your eating and your toilet hygiene, they're standalone. So CMS gave us a conversion chart. And they said, okay, if you code this on your MDS, it's going to convert over to this as far as your function score. So if you have a 5 or a 6 coded on your MDS, it's going to give you a function score of 4. If you have a 4 on your MDS, it's going to give you 3 points. If you have a 3 on your MDS, it's going to give you 2 points. If you have a 2 on your MDS, it's going to give you 1 point. If you use any of those 4 activity did not occur codes, so your 7, 9, 10, or 88, or if it's dashed, or if you have a 1, it's going to give you a function score of 0. Okay, so let's kind of put this into a scenario so that we can kind of see how it works. So over on your left column, these are those 7 GG items: your eating, toilet hygiene, sit to lying, lying to sitting on the side of the bed, sit to stand, chair to bed to chair transfer, and your toilet transfer. The next column over is what we coded on the MDS. So we coded it as a 4 or a 5, a 4, a 7, a 3, a 2, a 3, and a 3. Now we use that conversion chart to just convert them over. So we took our 5, gave us 4, and it's an individual score of 4. Our toilet hygiene was coded as a 4, so we get 3 points, and that's just taken over as an individual score. Now for sit to lying, we did a 7, which gives us 0 points, and lying to sitting on the side of the bed gives us 3 points, or we coded a 3, gives us 2 points. So we're going to take 0 plus 2, which gives us 2, divided by 2 gives us 1. So that's how we get that 1 score there. Then our next 3 were coded as a 2, a 3, and a 3, which gives us 1, 2, 2. So we take 1 plus 2 plus 2, which gives us 5. divided by 3, which gives us a 1.66666666. We're going to round it to a 1.6. We're not going to round it to a whole number yet, just in case there were other partial numbers. Okay. Then all you're going to do is you're just going to add that function score up. So we're going to take our 4 plus our 3 plus our 1 plus our 1.6, which gives us a 9.6. It's just simple rounding. 0.4 or below goes down to the nearest whole number. 0.5 or above goes up to the nearest whole number. So this would give us a 10. So for this scenario, the total function score would be a 10. After we calculate our function score, then we're going to dive deep into this hierarchy classification system, okay? We're going to start at the top, which is extensive services, and we're going to stop at the first nursing group they qualify into. So we have extensive services, special care high, special care low, clinically complex, behavioral symptoms and cognitive performance, and reduced physical function is at the bottom. If they don't classify into any of the other groups, they will automatically classify into reduced physical function. QRM has this amazing tool, which we affectionately call the Buzz tool, which has great information, and they have each of the components, but I want to focus specifically on the nursing component. So you can see here, it has all of those different nursing categories that we just talked about: extensive services, special care high, special care low, clinically complex, behavioral and cognitive performance, and reduced physical function. It also lists the GG scores as well as their PHQ-9 score and if they have restorative. So we're going to dive deep into each of these so that we can understand how a resident classifies into each of these groups. So the very first one is extensive services. And extensive services is unique because there's only 3 things, I guess 4 technically, that can qualify us into this component. You have your trach care, your invasive mechanical ventilator or respirator, and then your isolation. Okay, the reason why I say 4 is because you have your ventilator or respirator. Now, each of these things have to occur while a resident. So if they happened before the resident admitted to your facility, it doesn't count. It only counts if these things occurred while a resident. I do want to point out for isolation, there are very strict rules in the RAI manual. There's 4 criteria that a resident has to meet in order to code isolation on the MDS. So you want to make sure that you have documentation to support all 4 of those criteria before you code it. Oftentimes in a facility, especially with our IP nurse or infection control nurse, they will say something like, oh, this resident is on isolation. And then automatically we think, oh, we can code isolation on our MDS. But you have to really go and look at it and see, do they meet these 4 criteria? Because it may be, they may have them on isolation, but it may not meet those 4 criteria for the RAI. So make sure you understand those, look them up in the RAI manual before you code it as isolation. Now, if the resident has one of these nursing services, the next thing we want to look at is our GG function score. If it is a 15 or a 16, it will automatically drop to clinically complex. Remember, it has an inverse scale from what we had in section G. So section G, the higher the ADL score was, the more dependent the resident was. But with section GG, or our function score, it inverses. So the higher our score, the more independent the resident is. Okay, so in order to get into this extensive services, they have to have a function score of 0 to 14. So what this looks like when you're looking at the PDPM nursing classification is you have an ES at the beginning. That tells us it's extensive services. And then the end split is either a 3, 2, or a 1. The 3 tells me that they had a trach and a vent. The 2 tells me they had a trach or a vent. And the 1 tells me that they had isolation without a trach and without a vent. Okay, so extensive services is pretty straightforward. There's only those 3 things that can get you into extensive services, and then you're looking at the GG score. Okay, and you're only looking at the GG score to see if it's a 0 to 14. It actually doesn't play into the end split, which you will see it does as we look at the other categories. So we've got our special care high next. This is the next category. And we're going to look at several different conditions or services that qualify a resident into this category. So that's the first thing you're going to look at. And I've divided them up as to where you can find them coded on the MDS, just to kind of make it a little bit easier. So in section B, the only thing that can get us into a special care high in section B is if the resident is coded as being comatose and completely dependent or activity did not occur on admission for those items that we use to calculate the function score. It's those same items, right? Those late loss ADLs. So you've got your eating, your toileting hygiene, sit to lying, lying to sitting on the side of the bed, sit to stand, chair to bear, chair to bed to chair transfer, and then your toilet transfer. They must all be coded as either 1, dependent, 9, not applicable, or 88, not attempted due to medical condition or safety concern. Next, we've got section I, and I want to pause right here to talk specifically about section I. Section I is our active diagnosis section of the MDS. There are 2 criteria that must be met in order for us to code things as an active diagnosis on the MDS. The first one is there has to be physician or physician extender documentation in the last 60 days, and we have to be actively treating or actively impacting the resident's care in the last 7 days. So does that diagnosis actively impact the resident in the last 7 days? And do we have physician documentation in the last 60 days? Okay, so septicemia, again, it has to meet those 2 criteria. Diabetes, so first we have to make sure that it meets that criteria. Second, we're looking to see if they had insulin injections for 7 days and insulin order changes on 2 or more days. And those things are both coded in section N, but I left it here in section I because they have to have an active diagnosis of diabetes first, right? So with the insulin order changes, this can't simply be, oh, we had a sliding scale, they received, X amount of insulin because their blood sugar was 170. That's not an order change. An order change would be maybe completely changing their sliding scale or a different insulin order. The other thing that confuses people a lot is it's looking for the days, not the times. So maybe your physician made 3 or 4 order changes on day 1 of this day, but that would only count as 1, right? They have to have it on days is what we're looking at. The next one is quadriplegia. And with this one, the caveat is the nursing function score has to be less than or equal to 11. Then we have COPD and shortness of breath while lying flat. So COPD is a diagnosis that's going to be in section I, the checkbox, and shortness of breath is actually coded in J, section J. J1100 is where shortness of breath while lying flat is coded. So both of those things have to occur to get us into special care high. A lot of people miss this one because they have COPD, but they don't have shortness of breath while lying flat. So really assessing that to see if the resident shows any signs or symptoms or reports that they don't lay flat because of shortness of breath. Then we have section J, and you can get into this one by having a fever and one of the following. So a fever and pneumonia, a fever and vomiting, a fever and weight loss, and a fever and a feeding tube. Now, what constitutes a fever? You have to use the definition per the REI manual. So first, it's supposed to be 2.4 degrees or above their baseline. So you have to have a baseline established. If you don't have a baseline established, then a fever is 100.4 degrees Fahrenheit. That constitutes a fever. Okay. What constitutes a feeding tube? Is it any amount of feeding? No, CMS has said it has to have at least 51% or more of the total calories, or 26 to 50% of the total calories and 501 cc's or more of fluid through that tube daily. That's what constitutes a feeding tube. In section K, it's your parenteral feedings or IV feedings, and this can be while not a resident or while a resident. The key here is it's a 7-day look-back period. So that 7-day look-back period could extend into prior to admission, and that's where you would get your while not a resident, okay? The huge component of this and the part that has had the most focus over the last little bit is it has to be given for hydration, dehydration, or nutrition. So your documentation has to support that. And if you don't have documentation to support that, then you shouldn't be coding it. But this may require you to ask the hospital for their MARS. It may require you to ask for clarification from a physician when you're receiving that patient from the hospital. It may require to dig a little bit deeper into documentation to see if you can find the reason for the resident receiving this service. Okay. After we've looked at all of those things and we've determined that the resident classifies into special care high, we again look at that GG score. And if the function score is a 15 or a 16, again, they automatically drop down to clinically complex. Just like with our extensive services, with special care high, if their GG score is a 15 or a 16, they're going to drop down to that clinically complex category. Okay. Now, special care high also has a third step, and we're going to now be looking at your PHQ 2 to 9 or our PHQ 9 OV. The PHQ 9 OV is that staff assessment for depression. And so we're looking at the total severity score, whether we do the 2 through 9 or the 9 OV, we're looking at that total severity score. If it's a 10 or more, but not a 99, that says they have this depression end split or they have these signs and symptoms of depression. So what the nursing classifications look like is you have your ADL splits here. You have a 0 to 5 and you have your 6 to 14. Now, if you look over here on this final column, your H tells me it's a special care high. That's what that H means. Now, the BC tells me it's a functional score of 6 to 14. And the DE tells me it's a function score of 0 to 5. And now you have a 2 and a 1. And this tells me the 2 that the resident had a PHQ 2 through 9 or PHQ 9 OV score of 10 or above. And the 1 tells me they did not. Okay, so I'm just going to call this trigger for depression and not trigger for depression. Then we move on to our special care low, and you're going to determine if they have any of the conditions or services, just like we did with our special care high. Again, I've listed them by section so that it's easier to pull those out. Remember the 2 criteria in order to code it as an active diagnosis in section I, the physician documentation in the last 60 days, and then actively impacting the resident's care in the last 7 days. So for special care low, you've got your cerebral palsy, your MS, and your Parkinson's disease, which all require a function score of less than or equal to 11. And then the other thing in section I is respiratory failure with oxygen while a resident. And the oxygen is actually captured in section O of the MDS. For section K, we have a feeding tube. It has the same criteria as it did with special care high. The difference is with special care high, you had to have a fever and a feeding tube. With special care low, you just have to have that feeding tube. Then we have section M, which we didn't have any section M with our special care high, but this is where all of our skin issues are documented. So if the resident has a stage 3, stage 4, or unstageable due to slough or eschar with 2 or more selected treatments, they'll get into this category. If they have 2 or more venous or arterial ulcers with 2 or more selected skin treatments, they'll get here. Or 1 stage 2 and 1 venous or arterial will get them into this, and with 2 or more selected skin treatments, we'll get them into this category. They can also get here by having a foot infection, a diabetic foot ulcer, or other open lesion on the foot with a dressing to the feet. Okay, so you'll notice that last bullet doesn't require our special skin treatments. Those just require a dressing to the feet. Now, what are those special skin treatments? These are your pressure relieving chair and or bed, your turning and repositioning program, your nutrition or hydration intervention, your pressure ulcer injury care, or application of a non-surgical dressing or application of ointments and medications, and neither of those can be to the feet. In section O, you have your radiation or your dialysis while a resident. The second step for our special care low is again to look at our GG score. Just like with our extensive services and our special care high, if the function score is a 15 or a 16, they automatically drop to clinically complex. If it's 14 or below, then we're going to move on to our step 3, which again is looking at the PHQ 2 to 9 or the PHQ 9 OV. Total severity score is a 10 or a more, but not 99. Then they will get that depression end split, okay, or trigger for depression. So again, we only have our scores from 0 to 14 because if they're a 15 or a 16, remember they'll drop down to clinically complex. And then we have whether they triggered for depression or not. So again, the L tells us it's a special care low. The DE tells me it's a GG function score of 0 to 5, and my BC tells me it's a function score from 0 or from 6 to 14. Okay. And then the 2 tells me they triggered for depression. The 1 tells me they did not trigger for depression. The next category down is going to be our clinically complex. Again, just like with all of our others, we're going to look at the conditions and services that are listed to see if they qualify into clinically complex. So the first one is section I. This is pneumonia or hemiplegia or hemiparesis. If they have hemiplegia or hemiparesis, they also have to have a function score of less than or equal to 11. So those are the two items in section I that can get us into clinically complex. Remember, it has to have those two criteria: documentation in the last 60 days by a physician or physician extender, and actively impacting the resident's care in the last 7 days. We move on to section M. This is where they can have open lesions or surgical wound with selected treatments. And we'll look at the selected treatments in a moment because they are different than they were for your special care low. Okay. If they have burns, either at a second or third degree, and then here's our selected treatments: surgical wound care, application of a non-surgical dressing other than the feet, applications of ointments or medications other than to the feet. So it's important that you understand those selected skin treatments are different than they were for your special care low. Then we move on to section O, and all of these items had to have occurred while a resident in the facility. So still within the look back period, but while they're a resident. So we have chemotherapy, oxygen therapy, IV medications, and this is different from our IV fluids, and transfusions. After we figure out, okay, they go into this group, the GG score doesn't matter right away because you can have 0 to 16. So the next thing that we're going to look at is our PHQ 2 through 9 or our PHQ 9 OV. Again, a score of 10 or above will give us that depression end split. And now we're going to use the function score to determine where they are, what their classification is. So you notice you have more options now because we're going clear from 0 to 16. And we're going to look at the PHQ 2 through 9 or the PHQ 9 OV to say whether they have depression or not. And then our PDPM nursing classification. So our C tells me it's a clinically complex. The A tells me it's a functional score of 15 to 16. The BC tells me it's a functional score of 6 to 14. And my DE tells me it's a function score from 0 to 5. So the 2 and the 1, just like before, they're going to tell me if the resident has depression or not. 2 means depression, 1 means not. The next category is behavioral symptoms and cognitive performance. So the one thing to note is if the function score is less than 11, you're going to automatically skip to reduce physical function. And remember, less than 11 tells me that they're more dependent because the lower my score is, the more dependent they are. I can classify into this group either by behavioral symptoms or by cognitive performance. I don't have to meet both of those criteria. So let's look at our first step. If the BIM score is a 9 or less, they will classify into this group. So if you're looking at their BIM score and it's a 9 or less, they automatically will get into this cognitive performance group. Now remember, it's a hierarchy. So if they've already classified into something higher, then you don't even have to look at this one. This is just if they haven't classified into any of the higher groups, then we're going to look at this one. Okay. If the BIM score is greater than 9, but not 99, that means they don't classify for cognition. So we would skip to step 3 to see if they would classify for behavioral symptoms. Okay. If the BIM score was coded as 0, the resident was unable to complete the BIMS interview, then we're going to use the staff assessment. If the BIM summary score is a 99 or it's blank or dashed, then we will also use the staff assessment. So how you use the staff assessment for cognition is they can meet criteria by one of two options. So the first option is if they meet one of these that is listed below. So if they are comatose and completely dependent for those GG items that we use to calculate the function score, they will automatically classify here. Or if they're severely impaired cognitive skills for daily decision making, which is coded on the MDS, then they'll classify here. If they don't meet either of those, then we'll look at option 2, which says, okay, they have to meet the cognition criteria in 2 of these and 1 of these. So 2 of these, make self-understood is usually, sometimes, or rarely, short-term memory problem, impaired cognitive skills, or daily decision making. And 1 or more of the following, sometimes or rarely make self-understood, moderately or severely impaired cognitive skills for daily decision making. So those are the 2 ways that if you don't have a BIM score and you had to use a staff assessment, then you have to look at those options. If they didn't meet the criteria for either of those options, then we're going to move on and see if they classified based on any of the behavioral symptoms. And really, this is any of the behaviors that are coded in section E, okay? So if they have hallucinations or delusions at all during the look back period, then they'll categorize into here. Or if they had physical or verbal behaviors directed towards others, or other behaviors not directed towards others, rejection of care or wandering either daily or 4 to 6 days, they'll classify into this. So this is just a snapshot of what that looks like on your MDS. You've got your hallucinations and delusions, which it's simply just checking if they had those at all during that look back period. And then you've got your other behaviors, which gives you an option to choose. It didn't happen all the way up to daily. So essentially on your MDS, you have to have those items coded as a 2 or a 3. So if they get there either by cognition or by behaviors, then we're no longer going to look at our depression score. We're going to look at our restorative nursing count. We're going to see, did we provide restorative nursing and how many days did we provide that? So how do you figure out if they had a restorative nursing? On the MDS, it gives you an opportunity to code how many days the resident received restorative therapy. And in order to have it count towards this nursing component, you had to provide it 15 or more minutes a day for 6 or more days of the last 7 days. So again, if you're setting your ARD on day 3, you're not going to be able to capture this because it has to be at least 6 of the 7 days, okay? Or six days, 15 minutes in 2 or more categories for 6 days. So you've got your urinary toileting program or bowel toileting program. You've got your passive or active range of motion, your splint or brace, bed mobility and or walking training, your transfer, your dressing or grooming, your eating or swallowing, amputation, or communication. So we talked about if your GG score was a 10 or below, then you were going to be pushed to reduce physical function. So if it was 11 to a 16, that gets you into the behavioral symptoms and cognitive performance. So you have your 11 to 16, your restorative count. If you have 2 or more, it's going to get you your BAB2. So my B is what tells me it's behavioral symptoms and cognitive performance, and my AB tells me it's the function score of 11 to 16. The 2 tells me I had 2 or more restorative programs. My 1 tells me I had 0 or 1 restorative programs. The last category is reduced physical function. So like I talked about at the beginning, anybody who doesn't meet the criteria for the upper categories automatically falls into reduced physical function. So the only thing that we are then looking at is our restorative program. And remember, to count as a day, there has to be 15 or more minutes. And then in order to count as a program, it has to be 6 or more days. And to actually get the end split or the credit, to have it count for this, you have to have 2 or more programs. So those are listed here again for your reference. So for the reduced physical function, it includes all of our functional scores from 0 to 16. And then we're looking at our restorative program. So again, the P tells me it's that reduced physical function. The A tells me it's a 15 to a 16, so highly independent residents, right? My B to C tells me it's a 6 to 14, and my DE tells me it's 0 to 5. The end split, the 2 and the 1, 2 tells me I have 2 or more restorative programs. The 1 tells me I have 0 or 1 restorative program. So here again is that snapshot of the Buzz tool. You've got your trach care and your vent care. You've got your isolation and your extensive services. You've got your special care high, special care low, clinically complex, behavioral symptoms and cognitive patterns, and then your reduced physical function. On this Buzz tool, we have your GG scores or your function score that can be there, the depression criteria, yes or no, and then the restorative program. So it's all there in a quick snapshot for you. So a couple of things I want to end with. I really want to emphasize how important it is for you to pay attention to look back periods and pay attention to if that look back period allows you to go back to while not a resident. That's very important. You also have to have the documentation to support anything that you code on the MDS. You have to have documentation to support it. There has to be paper documentation in the chart. It's not enough for you to just know something. And that's why it's super important that you're looking at documentation during the look back period so that you have an opportunity to go and ask the staff probing questions, to go and interview the resident, to go and interview staff, to go and do observations, to get feedback from the direct care staff and from charge nurses and from physicians so that you can get an accurate picture of what is actually happening with your resident so that it can be accurately coded on the MDS. It's not enough just to wait until after the ARD and say, it is what it is. I can't help the documentation. You have to be actively and proactively seeking that information so that you can have an accurate MDS. And that is something that I will always, always emphasize. That's something that QRM feels very strongly about is accurate coding. That's all we're going for is accurate coding. Timeliness of resident interviews. This comes up again and again and again. Your BIMs and your PHQs have to be done on time and documented that they were done on time. This is an easy, low-hanging fruit for your Medicare payers, your Medicare-like payers, and now your Medicaid payers to be able to take that money back because it wasn't done on time. So you want to make sure that you understand what the RAI manual says when these interviews have to be done and that you're doing them timely. You want to start at the top of the nursing categories and you work your way down. If you start at the bottom, they may classify into something higher that you may not have realized. So always start at the top and you work your way down. And again, Accuracy, accuracy, accuracy. That's your number one focus. But you're going to have to be proactive about making sure that it's accurate, right? We have to provide that care and then get our accurate documentation to accurately code the MDS. There are a couple of other considerations that I want you to think about as well. This could potentially cause an increased workload. There's going to be additional required documentation, and it may require more collaboration with your team in order to get the correct, accurate documentation, to get the correct coding. You want to make sure that your source documentation for the MDS is succinct and it's a place that can be easily identified. So who is assigned to complete these different tasks? And then what form of documentation is going to be used? Are you going to use a UDA, a flow sheet, an IDT note, something completely different? Where are you going to keep this documentation? Some of it may be in hospital documentation or primary care physician documentation. Some of it may be in dietary notes. Some of it may be in physician progress notes. You have to make sure that you know where that documentation is and make sure that it's in the medical record so that it can be validated that it was correct. You need to know when this documentation needs to occur, right? If we're not getting this documentation until after the ARD, we're going to be in trouble. What's the look back period for this item? Pay attention to section GG. When does my documentation have to be in the chart? What is my look back period? And then where is that supporting documentation going to be? Do we have a specific place in our medical record that we're keeping it so that we can easily identify and support that coding? Making sure that we understand what needs to be documented and making sure that we have a good place for it to be. Thank you so much for your time today. I want to go over really quickly what QRM has to offer as far as MDS oversight. We can provide reimbursement capture auditing. We do state-by-state case mix index management. So our teams know each of the state's case mix models really, really well. And we have created tools to help facilities be successful in getting reimbursed for the care that they are providing, to get reimbursed for that burden of care of that resident. We offer interim remote MDS coverage, MDS completion and compliance auditing, quality measure and 5-star auditing and support, REI-based education and training, as well as trending analytics. You can always visit us on our website. And if you have any questions, feel free to reach out. Like I said, my name is Stacy Grondel. I'm the Director of Clinical Reimbursement, and my email address is sgrondel@qrmhealth.com. Thank you so much for spending time with me today, and I look forward to future interactions.